last speaker of the day, Dr. Srirangalakshmi Pandyan. Dr. Pandyan is an accomplished orthodontist that holds a BDS from the Government Dental College in Chennai, Master in Dentistry from Babuji Dental College, and a Master in Orthodontics from the Royal College of Surgeons in Edinburgh. She is an Associate Professor and Academic Head at Savitha Dental College, Chennai, and a consultant orthodontics in private practice. Her niche areas include digital planning for aligners and orthodontic surgery. She is also a dedicated researcher with over 70 index publications and has delivered more than 40 guest lectures. She serves as an examiner for Master Ortho examination at the Royal College of Physicians and Surgeons in Glasgow, and she has received awards as the best trainer and best outgoing postgraduate student. She is also the recipient of WFO Roberto Justus Rising Star Scholarship. Actively, she is engaged in teaching and practice, and she continues to push forward orthodontic education and research. So, Dr. Pandyan, we're ready to
Thank you.
see your
Thank you for the warm introduction. Good evening, everyone, and I thank you for staying back for the lecture, and I hope it will be very, good, memorable lecture for you. So, I'm Dr. Srirangalakshmi, and I'm the proud recipient of the Roberto Justus Young Speaker Travel Scholarship by the WFO, and I'm very grateful to the World Federation of Orthodontists and the President, Dr. Niklesh Ved, for being a good mentor that he is to me. So I come from India, and I represent the Indian Orthodontic Society, and I stay in the southern part of India at Chennai, which is a land of beautiful beaches and temples. And this is the college where I work, and that is the private practice where I practice orthodontics. So I extend a warm welcome to all of you to visit my country and my college and my practice any time of the year. You're welcome. So what connects India and Greece? So if you see, the Hippocrates was a wonderful contribution from Greece to the world. In the world of medicine, we still take the Hippocratic oath. And from the land of India, we have Sushruta, who is considered the father of surgery. So that makes an interesting connection for me to be here to talk about nothing other than the surgery first orthognathic approach and the controversies. So I will be referring this as SFOA from now on. So any concept, when it is introduced, goes through 3 stages: denial, skepticism, and acceptance. So SFOA was not an exception to it. In the beginning, people were reluctant to adopt this technology because they simply did not believe in it. And with published case reports and evolving evidence, it was accepted with skepticism, and now we have enough robust evidences, systematic reviews, and meta-analysis which supports the technique of surgery-first orthognathic approach. So we are very aware of when to do the surgery-first orthognathic approach. So I wanted to highlight here that when you do a surgery, just not stick on to one technique, because when you adopt surgery-first orthognathic approach, you might have to use the techniques of the skeletal anchorage as well, which we'll be seeing during the course of my presentation. The next question you should ask me is, why SFOA, why not conventional? Well, to me, it improves the quality of the life of the patient, and it also decides the time of the surgery. So the patient is very sure when the time of the surgery is, so they can plan their life and the activities around it. It also reduces the duration of the treatment, and it avoids the profile worsening during the pre-surgical phase in the conventional treatment. Yes, is it very important? Of course, because it has a psychological effect on the patient. This is for the conventional treatment during the orthognathic surgery, wherein you see there is a dip of the patient's psychological level during the pre-surgery and immediately just after post-surgery. So, can we avoid this with surgery-first approach? Of course you can, and we have enough evidences to say that we are improving the quality of life with this technique. So, let me move on to the claimed advantages of this approach. We have a good improvement in facial profile with reduced treatment duration. And interestingly, the patient are more compliant for the orthodontic treatment because they are more positively motivated to continue the treatment. There is increase in the accelerated tooth movement because of the skeletally accelerated phenomenon. We have been employing regional acceleratory phenomenon, but when we perform an orthognathic surgery, there's an overall boost of the metabolism which contributes the skeletally accelerated phenomenon. And because we are addressing the jaw problem in the beginning, there is enhanced soft tissue response because your orthodontics is in tandem with the jaw basis. And of course, we have seen that there is enough evidence to support that it improves the quality of life. Now, when all it is indicated, to begin with, we can start with non-extraction cases where we have mild to moderate crowding and there is near normal inclination of the upper incisors. Of course, we need an adequate transverse relationship upon the correction. Can we do this approach in all the cases? I'm afraid not so, because we have few contraindications. Whenever we have cases with TMJ disorders, it is important to address the joint and then we perform with the orthognathic surgery. And in cases where we have multiple missing teeth, it is difficult to achieve a post-surgical occlusion. It is referred to as the transitional occlusion. So if there is no stability, then the results are not going to be stable. And in some syndrome cases, it would be beneficial to go in for a short course of orthodontic treatment and then proceed with the aligning of the jaw bases. So when do we bond in surgery first approach? Is it 1 week before the surgery, after the surgery? There are multiple protocols. You et al. Recommends to bond 1 week before surgery. Co et al. Recommends to bond 1 month before surgery. You can also bond 1 week after the surgery if you employ indirect bonding. But in our practice and in my experience, we bond just 2 days before the surgery to keep it passive, and on the table, during the surgery, that is immediately after the surgery is done, we place the orthodontic wires. So your orthodontic treatment starts at the orthodontic table. So there is less discomfort for the patient when they come for the checkup. Regarding the elastic wear protocol, it is important to retain whatever results we have achieved. So we advise to start the elastic usage within 1 week after the surgery. And we should at least continue for a minimum of 3 months post-surgery. What are the various treatment planning considerations that we have to consider? First is the 6 degrees of freedom. Now, what are the 6 degrees of freedom? We know that we have 3 linear movements: the sagittal, vertical, transverse, and apart from this, we also have the pitch, roll, and yaw. So it is important to understand that you can move a jaw base in the 6 degrees of freedom to your advantage and to obtain a beautiful result. Next, overcompensation. Yes, in conventional approach, we treat exactly what is needed. But in surgery first approach, for the jaw bases, we treat beyond. That is, we overcompensate so that we have it ready for the post-surgical orthodontics. And it is important to consider upper incisors because after all, we all strive for the patient to smile. And how important is upper incisors in smile? Very important. And we have to take into consideration the growth pattern and the role of transitional occlusion. So I will be showing you a series of cases through which I will be emphasizing the above mentioned treatment planning considerations, and I'm going to keep it purely clinical because I believe your patients are your true teachers and every smile has a story to tell. So let's explore into the first concept of 6 degrees of freedom.